Hello everyone, welcome to another pathology video. In this video, we will be discussing about a very important topic on the chapter WBC, which is Hodgkin's lymphoma. Before moving on to Hodgkin's lymphoma, we should know what are the features which differentiate between Hodgkin's and non-Hodgkin's lymphoma. Hodgkin's lymphoma is localized to a single axial group of nodes, whereas non-Hodgkin's lymphoma frequently involve multiple peripheral nodes. The fashion of spread is contiguous in Hodgkin's lymphoma, whereas it is non-contiguous in non-Hodgkin's lymphoma. Mesenteric nodes and Valdeye's ring are rarely involved in Hodgkin's lymphoma, whereas they are more commonly involved in non-Hodgkin's lymphoma. Extranodal presentation is usually rare in Hodgkin's lymphoma, whereas it is more common in non-Hodgkin's lymphoma. Now, what is Hodgkin's lymphoma? It is a tumor which arises from a single node and spreads first to anatomically contiguous lymphoid tissue. Morphologically, it is characterized by the presence of Reed-Sternberg cells. Now, let's move on to pathogenesis of Hodgkin's lymphoma. We already saw Reed-Sternberg cells are the characteristic of Hodgkin's lymphoma. They originate from the germinal center or post-germinal B cells. There is activation of nuclear factor kappa B, which promotes the growth and survival of Reed-Sternberg cells. This Hodgkin's lymphoma is often associated with Epstein-Barr virus infection. In cells infected with Epstein-Barr virus, there is expression of latent membrane protein 1, which activates nuclear factor kappa B, which further promotes the growth and survival of Reed-Sternberg cells. In cells lacking the infection of Epstein-Barr virus, there is loss of function mutations of TNF-alpha-induced protein 3 or 1 kappa B. These are basically the negative regulators of nuclear factor kappa B. Since negative regulation is lost, there is overexpression of nuclear factor kappa B, which promotes the growth and survival of Reed-Sternberg cells. Other than Reed-Sternberg cells, there is also accumulation of other reactive cells, which occurs by response to various cytokines. Morphologically, Hodgkin's lymphoma is classified into 5 types: nodular sclerosis, mixed cellularity, lymphocyte rich, lymphocyte depleter, and nodular lymphocyte predominance. Out of these 5, the first 4 are considered as classical forms of Hodgkin's lymphoma, whereas the last type, nodular lymphocyte predominance, is the non-classical form of Hodgkin's lymphoma. Now let's move on to morphology of Hodgkin's lymphoma. Since we already saw, Reed-Sternberg cells are the characteristic of Hodgkin's lymphoma. They are large cells with multiple nuclei or a single nucleus with multiple nuclear lobes, each with a large inclusion-like nucleolus. Roughly, a Reed-Sternberg cell is triple the size of a normal WBC cell. This is just a diagrammatic representation of how a classical Reed-Sternberg cell appears. They are large cells, of course. They have abundant eosinophilic cytoplasm. Typically, most of the Reed-Sternberg cells which we encounter will be having two nuclei, which gives a mirror image kind of thing. And there is prominent nucleolus surrounded by a halo. There are also some other variants of Reed-Sternberg cells. Mononuclear variant. It just contains a single large round nucleus with a large eosinophilic inclusion like nucleolus. Next is lacunar variant. It consists of a water-clear cytoplasm, large folded nucleus with one or more prominent nucleoli. Next is mummified cell variant. These are nothing but Reed-Sternberg cells of classic variant which undergoes cell death becomes the mummified cell variant. It consists of dark eosinophilic cytoplasm with shrunken or pycnotic nuclei. Next is pleomorphic variant. They just contain large bizarre hyperchromatic nuclei with nucleolus. Next is LH variants. They contain abundant pale cytoplasm and the nucleus is polypod with inconspicuous nuclei, giving rise to a shape similar to popcorn kernel. That's why these LH variants are called as popcorn cells. Now, let's move on to morphology of individual subtypes of Hodgkin's lymphoma. First is nodular sclerosis. It is the most common form of Hodgkin's lymphoma. This is just a diagrammatic representation of how the morphology in microscope appears. There is deposition of collagen bands which divides the involved lymph node into circumscribed nodules. Reed-Sternberg cells are formed in the background of T cells, eosinophils, macrophages, plasma cells, and other reactive cells. This form is characterized by the presence of lacunar variants of Reed-Sternberg cells. This form is not commonly associated with Epstein-Barr virus infection. Now coming to the immunohistochemical markers, this form is positive for CD15, CD30 and PAX5 and it is negative for CD45. Not only this, all the four classical forms of Hodgkin's lymphoma have the same IHC markers. Moving on to the next type, mixed cellularity. As the name implies, there is mixed cellularity. So the cellular infiltrate consists of mixture of cells like T cells, eosinophils, macrophages, plasma cells, and also Reed-Sternberg cells. Diagnostic Reed-Sternberg cells and their mononuclear variants are plentiful in this form. Most of the cases of this form are associated with Epstein-Barr viral infection. Since it's a classical type, it shares the same IHC markers, same as nodular sclerosis, which is CD15 positive, 30 positive, PAX5 positive, and CD45 negative. The next type is lymphocyte rich. As the name suggests, it is lymphocyte rich. So the lymphocytes make up the vast majority of the cellular infiltrate. There is also another form called lymphocyte predominance, which also by name suggests that the lymphocytes make up the majority of cellular infiltrate. But both are distinguished based on the feature that this type has the presence of frequent mononuclear variants and diagnostic Reed-Sternberg cells with classical immunophenotypic profile. Next type is lymphocyte depleter. It is the least common form of Hodgkin's lymphoma. It usually occurs in older adults and HIV-positive individuals. As the name suggests, it is lymphocyte depleted. There is paucity of lymphocytes and a relative abundance of Reed-Sternberg cells and their pleomorphic variants. Most of the cases are associated with Epstein-Barr virus infection in this form. Since it is also a classical form, it shares the classical IHC markers CD15 positive, 30 positive, PAX5 positive, and CD45 negative. Now coming to the final type, which is nodular lymphocyte predominance. It is the non-classical form of Hodgkin's lymphoma. There is nodular, so the involved nodes are effaced by nodular infiltrate of small lymphocytes, and also there is mixture of macrophages in it. The LH variants of Reed-Sternberg cells are the characteristic feature of this type. Eosinophils and plasma are usually absent in this type, and this type is not associated with Epstein-Barr viral infection. Coming to IHC markers, since this type is non-classical, the classical markers of CD15 and CD30 are negative here. The positive ones are CD20 and BCL6. Now, coming to the clinical staging of Hodgkin and non-Hodgkin's lymphoma. It is given by a staging called Ann Arbor's classification. It, the disease has been staged into four stages based on the distribution of disease. In stage 1, there is involvement of a single lymph node region or a single extra lymphatic organ. In stage 2, there is involvement of two or more lymph node regions on the same side of diaphragm. Whereas in stage 3, there is involvement of lymph node regions on both sides of diaphragm. In stage 4, there is diffuse involvement of one or more extra lymphatic organs with or without lymphatic involvement. Further, all of these stages are divided into A or B based on the absence or presence of the following symptoms, which is unexplained fever, night sweats, and unexplained weight loss of more than 10% of normal body weight. Most of the cases of Hodgkin's lymphoma clinically presents as painless cervical lymphadenopathy. Patients with nodular sclerosis or lymphocyte predominant types tends to have stage 1 or stage 2 of disease and are usually free of systemic manifestation, whereas patients with disseminated stages, that is stage 3 or stage 4, tend to have mixed cellularity or lymphocyte depleted types, which are more likely to have constitutional symptoms such as fever, weight loss, and night sweats. That's it about Hodgkin's lymphoma. Thank you. Feel free to give your feedback in the comment section. Thank you.